should be good to go shortly. Start the webinar live on Facebook. That one. This one. Next. That one's just a bit narrower than this one. So yeah, we'll just come in close to this one.
So standard social distance.
Yeah. Okay. Yeah, let's see this. Try and set this one up. Take 2. This one. There we go. Checking connection. Awesome. Very good. All right. Well, thank you very much for joining, Brian. And good for some people to be joining Instagram, Facebook, and on Zoom. So an informal chat. Brian Devitt, orthopedic surgeon at Ortho Sport Victoria.
Correct.
I'll let you introduce yourself a little bit to the local community that we've got.
Yeah. So my name is Brian Devitt. I'm an orthopedic surgeon now from Ireland. So I've been here in Australia for the past 6 years now. I originally came here on fellowship in 2014, and I've just been away to the US for a year doing a research fellowship in Vail, Colorado, and then spent a year in Toronto doing sports medicine fellowship in orthopedic sports medicine. And then I came to Australia, to Melbourne, which is regarded as one of the centres of excellence for knee surgery in Australia, but also the world. And worked with Julian Feller and Tim Whitehead and Cameron Norsworthy in knee surgery. And then I also worked with John O'Donnell in hip arthroscopy. So I liked it so much these days. So I'm here 6 years and probably here forever.
Sucked into Melbourne, right?
Yeah, it was certainly a great city and very much a sporting city, which is exactly what I like.
We went from Colorado to Toronto, all good ski cities, but there's not that much.
Yeah, Toronto, yeah, Colorado definitely skiing. Toronto less skiing and maybe a little bit of cross country skiing, plenty of snow, and then no snow whatsoever. Plenty of sport, plenty of ACL injury.
Yeah. No, that's good. Well, it's going to be an informal chat. We've got some questions from plenty of the local community and a couple of strength and conditioning and PTs in the area as well. But you've just recently finished your PhD.
Yeah,
Can we talk a bit about that?
So, I suppose one thing to happen to come out of the COVID restrictions, having plenty of time to sit and write it up. So, I embarked on a PhD 4 years ago, and it really came on the back of the anterolateral ligament, which was discovered in 2013, and it was hailed as being the great panacea in terms of the treatment of the injured knee. And people tried to promote it that this finally explained why people who had ACL injuries and despite reconstructions went on to have further injuries. And the anterolateral ligament, as the name suggests, is on the front and outside of the knee. And they thought that it was able to control rotation that couldn't be controlled by the ACL, which is the center of the knee. So I was a little bit dubious about whether this was, it sounded too good to be true, that it's just one solitary structure. So I set out to investigate it and then to do some diagnosis of anterolateral laxity, so rotatory laxity of the knee. And so we did a lot of MRI studies in that. And then we looked at a technique which we use called the lateral extraarticular tenodesis. So one particular variety of that we use, which can control rotatory stability. So we use that in conjunction with ACL reconstruction. And so Julian Fellow, my colleague, has recently done a study looking at high-risk individuals and performing this procedure in addition to an ACL reconstruction, and shows that there's a very low rupture rate. And so, yeah, that's essentially the theme of my thesis. Actually, it's been awarded, so it's great to get the cap on and have the day out if we never get there.
How often do you do that extra-articular?
More and more nowadays. I think you know, we used to just do it in the setting of a revision ACL, and I suppose the principle that the definition of madness is doing the same thing twice and expecting different results. So we wanted to do something that would be kind of both embraces, you reconstruct the ACL and do something to control the rotation. But more and more now we're looking at those high risk individuals who might be, you know, at greater risk of re-injuring. And you know, in Australia, we've got the highest rate of ACL reconstruction in the world. And you know, the rates have been increasing over the last 15 years, but so too have the rates of re-injury. So I think we, as surgeons, need to be aware that potentially there are those groups with primary ACL that we need to do something extra to control that rotation. So we're doing it in, you know, young male patients, young female patients, patients with hyperlaxity, patients who have perhaps more chronic ACL that have had a stretch of those structures in the outside of the knee, or multiple what they call pivot shift events, so that they've gone over and stretched their structures, and we do it just to protect them, provide that extra stability.
Okay. There's a couple of really interesting questions that have come through regarding regrowth of ACLs, and at what point do you decide that you need surgery versus going down a conservative route? What are your thoughts on that as an overall topic, and then we'll delve into a bit more detail.
Yeah, well, I think, you know, there's certainly ACL reconstruction is not for everybody. I think that's from the start, and I think there are certain people who have an ACL rupture and don't require an ACL reconstruction.
Yeah. What might that look like? What kind of
I suppose you look at someone's demand. So I think that if you look at someone potentially in their 30s or 40s who are not playing, you know, pivoting sports, who are maybe just recreational athletes, or just gym-going athletes that don't involve a lot of pivoting, there's a certain potential that they won't require an ACL, and they can rehabilitate and they can get fantastic function. As to the ACL regrowing, it's not like it regrows, but it certainly does heal, and it depends where it's been ruptured. And that is often dependent on the mechanism of injury, but also velocity of injury. So you can have a situation which happens in children a lot, where it peels off the femur, or even more high velocity injury where you get intrasubstance tearing. Now, intrasubstance it's very unlikely that's going to heal to normal integrity, but what it does do, it heals back to the PCL. So it provides some stability, normally in the frontal plane, less so in the rotatory plane. But if you rehabilitate properly, then a lot of people can actually do very well without an ACL reconstruction.
They're talking runners in a straight line, maybe marathoners, rowers, those kinds of linear sports.
Yeah, certainly. And I think it comes down to patient symptoms as well. I think there's often, you know, you look at high elite athletes, or athletes who play a lot of high, you know, risk sports, a lot of pivoting sports, that probably would benefit more from having an ACL reconstruction, because you want to provide that stability to their knee. When the ACL is deficient, the other structures take over. So your meniscus, particularly the median meniscus, takes over as a stabilizing structure. And if you're to have a further pivoting event, you're at greater risk of injuring the meniscus. If you injure the meniscus, you know, the potential for chondral damage, and that's much more difficult to fix. And I think that's why in that higher risk group, we recommend earlier acute ACL reconstruction, and it's been shown to reduce the risk of further injuries in doing so. But there then is the other group, as you mentioned, the less high demand group, and you'd certainly give them an opportunity and let them rehabilitate them properly. It's not just let them sit on the couch, and that's where you guys come in terms of, you know, making sure that they have no effusion before they get get to running, making sure they've got their strength and their range of motion, most importantly.
Yeah.
And particularly your full extension. I think that's really key. And then if those patients go on to have further instability episodes, then they may ultimately come to ACL reconstruction, but you certainly give them the opportunity to rehabilitate before you would go for surgery.
And so looking at the EPL, an example, Virgil van Dijk just ruptured his ACL, and he's gone in, and most of these EPL guys will go in and have surgery.
Yeah.
That's because they're in the high risk change of direction group, aren't they?
Yeah, absolutely. And for his injuries, very fortunate, and but he's going to be probably has had his ACL, I suspect, already, because they do it so acutely. You'll get into the surgery the next day.
Yeah.
And within that group, particularly soccer players, they will need their ACL, pivoting on a sixpence, as they say. They're going to need that stability.
Yeah.
And similarly for AFL, particularly the sports that we see, is that there's a lot of they're very high risk, and that's probably one of the reasons why Australia has the highest rate of ACL reconstruction, is because the sports that are played and because the number of people that play in society. I think particularly with AFL, it's a sport where the ball's in the air, it's an oval ball, so that it's unpredictable the way it bounces, and people have high risk of ACL injury, very similar to daily games, and they have a very high rate of ACL rupture in Ireland as well in their sport.
Okay. The overall landscape of doing ACLs in Australia, do you think there is much more that we can be doing? And if so, what do you think we're kind of missing compared to the rest of the world?
Well, I think, first of all, we realize that prevention is better than cure. So if you have a young person with an ACL injury, it's a really tragic event, because they lose a very important structure within their knee that is protective of their knee. And even if you do reconstruct the ACL well, particularly in the young group, they have a high risk of re-injury, but then they have a high risk of developing osteoarthritis later on down the line. So Tim Hughes is a very good biomechanist and scientist, and he's shown how effective doing these injury prevention programs are. And as a surgeon group, we really support that. I think with the likes of Netball Australia and the AFL in terms of and FIFA 11, and doing these pre-implementation, doing these series of exercises before you train are really important. And they're shown to reduce the rate of ACL injury up to 60%. So I think that's really key. I think we have to get that across. And then when you do an ACL reconstruction, it does come to a point where you need the surgery. You want to do it right so that you're going to limit the risk of re-injury. But we also have to be cognizant of the fact that patients, or particularly young patients, they're high risk. They put themselves in harm's way again. So if you didn't want them to rupture ACL, you'd probably tell them to stop playing sports. But life's for living, and you have to allow people to go back to their sports if they so wish, as long as they're aware of the risks. But equally, I think you have to try to do the surgery as best you can to prevent further injury. Yeah. But then that's the part we do. That's the part that takes an hour to an hour and a half. Yeah. The most important part is where it comes to rehabilitation. And I think that it's no longer just the surgeon making a decision on whether someone goes back to sport or whether they're ready to go back to sport. It's a combined decision with strength and conditioning coaches, physiotherapists, exercise physiologists, the surgeon, and most importantly at the center is the patient. Provided they understand the risk.
One of the biggest things that we really try to implement is, alongside working with the surgeon, is collecting objective data in terms of muscle strength, but also quality of landing, quality of jumping, quality of change of direction activities. And so that's one of the things that, for the local community, that warm-up is so important to enable people to go through injury prevention and reduce the risk of seeing. But we know that it's going to happen. So when someone does rupture an ACL, what can they expect from you in a consult? Yeah,
that's good. I think most patients nowadays, with the availability of MRI scans, and most of them go see a physiotherapist. Physiotherapist sees them on the side of the pitch, and they come into us. So essentially, we come in. First assessment is you want to find out about the mechanism of injury. So you look at an individual, how they did it. The vast majority of ACL injuries injuries are non-contact. So it's a pivot, it's just an unfortunate event. So the consultation, really, the first part of it is the history, so we just talked about that. Figure out, if someone has a twisting injury, they sometimes feel a pop, they fall to the ground, they hold their knee, it's ACL until proven otherwise. We then figure out, did they get swelling immediately, and to go through how they went in the early post-operative course until the time they got their MRI. And a lot of them have seen physios beforehand. They get the range of motion going, which is really critical in terms of being ready for surgery if surgery is required. The second part of the consultation, so first the history, and also within the history we look at risk factors. So we look at family history, any injury to the opposite knee, brothers, sisters having ACL injuries, parents having ACL injuries, and then what type of sport they have at what level. So we're kind of trying to stratify the risk of further injury potentially. The examination then can be difficult in the acute setting because patients are generally a little bit sore, swollen, but essentially what we want to do is look at their alignments. So I always get patients that wear shorts, we stand them up, we look at them, they're always standing with their knee kind of semi-flexed, and they can't weight bear because they're a bit swollen.
Usually when they come in to see you, so this is in a consult room, it's not in a surgical theatre.
No, it's very relaxed. We're chatting away. It's very relaxed environment. Consultation typically takes around 20 minutes.
Yeah.
Patients have plenty of time to tell the story uninterrupted, and then we go to the examination. It takes around 5 minutes.
Yeah.
Examination, when somebody's sore, we're not there to hurt them. We're there to try to elicit which structures they injured in addition to their ACL. So we do an examination then. Once we've looked at them walk, we looked at their alignment, and then we assess for range of motion. So while ideally, anybody going for surgery needs a full range of motion, because you're not going to get it after surgery unless you have it beforehand. And then we want to really hone in on which structure is injured. So we look at the ACL laxity test. So we're assessing for laxity in a number of different planes, so rotatory and frontal laxity, and also to see if they've injured any collateral ligaments as well, because that can happen. And then probe to see if they've got any tendons in their menisci, which can be an injury we need to address at the time of surgery. And then what I always do with my policy is to look through the MRI with the patient. So we give little clues as to what we're looking at. And, the picture tells 1,000 words. So if you see what's going on, you can much better understanding. And we often then use models potentially, or draw pictures, or speak about what is entailed in the surgery. That's really important then, because lots of people would know friends who've had injuries, but it's different when it's you, and you need to be aware of what the risks are of surgery, and also the risks of returning to sport as well, because for one is for on. I think a lot of people are a little bit clouded when they come in. It's a big tragedy for them, but you have to kind of spell it out, give them time, and explain what's involved.
Now, if someone comes to see you, does it necessarily mean that you'll have surgery?
No, not at all. And I think that's where the history is so important. And that's when we look at the scan, and then we make a decision. The decision is a decision, combined with the patient. It could be a younger patient with their parents, and no decision needs to be made on the spot either. Yeah. So if there is a consultation needs to be had with a physiotherapist, we just give everything time. And that's the one thing about ACL surgery. There's never really any indication, or a few enough times there's an indication to do something acutely. There's always a bit of time. Situations where you have a meniscal tears, they might, particularly bucket handle therapy, meniscus is flipped and you can't straighten the leg. That might increase the urgency of surgery, but you always have time to discuss and for patients to go away and think about it, because it's a big deal. But a lot of times patients come to us, they've spoken to physiotherapists, they have an idea as to which path they're going to take, and then it's for us just to make sure that they're informed and they have all the information.
Now, I know that we see a lot of meniscus tears, or say a posterior cruciate tears, that we will send for an opinion, what we call an opinion from the orthopedic surgeon, and that's where we'll work collaboratively to determine, okay, is surgery required, or what are the other options? Do we attempt 6 weeks of rehab? Do we attempt 6 months of rehab? So it's not always that people go in, because I feel like, especially in the local community, there's a few people that would say, I don't want to go see a surgeon because it means that I'll get chopped open.
Yeah, no, and I think, there's in the past, perhaps there's some people, have that impression because of their experiences, their experiences of someone else. But I think very, very much so, we don't want to do surgery on people who are going to get better of their own accord.
Yeah.
And I think that's where the open lines of communication are much better. And I think that, you come to surgery with many surgeons, and myself included, and that just improves those lines of communications because we see what's going on. We talk all the time, so we frequently text each other about cases coming up, and definitely for patient, surgery is not first option for many cases. And there's a great phrase by Voltaire. He said, "Medicine is the art of distracting the patient while nature heals them." So that there's lots of things that will get better for on court.
Yeah.
But I think the key part of that is that you give something a trial. So it's, people talk about conservative management, but conservative, for me, gives the impression that you're sitting down and doing nothing.
Yeah.
But non-operative management, I think, is better because that entails rehabilitation. And I think if rehabilitation is failing, or if you're not getting any further gains, potentially surgical intervention might be required, but certainly not always.
Yeah. One of the things with knee injuries, so let's go down the track of meniscus repair.
Mm.
First off, two-part question. What is a meniscus repair and what does it entail?
Mm-hmm.
And the second part, we'll delve a little bit more into that informed consent aspect of surgery versus rehab in meniscus and ACL.
Yeah, okay, yeah. So, well, the meniscus of itself is you have two menisci. They're kind of crescent-shaped structures in either side of the knee, so the lateral and medial. And the meniscus itself is like a shock absorber. It's a wedge shape when you're looking at it from the side, and it essentially provides stability to your knee in addition to dissipating the load. So sharing the load when you walk, and it's a very important structure. It's a very commonly injured structure. So you can injure it traumatically with the likes of an ACL. Injuries are quite common. But as you age, just like you get gray hairs and wrinkles, your meniscus loses its water content and becomes more brittle. Mm-hmm. So you can have degenerative meniscal tears where someone's it just gets a little dry over time, and then a small innocuous twist can tear the meniscus. So a meniscus repair is trying to put the or heal, allow the meniscus to heal. That's one of the big problems with the meniscus. It doesn't have a good blood supply. Yeah. So it has a blood supply in the periphery, but not within the body of it in a large number of cases. So there's a limit in terms of what you can expect nature to do for a meniscus. But if a meniscus is undisplaced and it's a peripheral tear and there's no movement on the meniscus, we very much rather let nature heal it. So we leave it alone and just rest and try not to cause any further exacerbation. So you typically give it up to 3 months from the acute injury to let it settle down. Yeah. In that time, you want to control the swelling in the knee and allow the muscles to activate, because the muscles activate as shock absorbers as well. So you need to get them activated.
That's where that physio is really important in terms of getting your quadriceps and your hamstrings and your adductors and glutes working.
Yeah, absolutely. And essentially, in those cases, a lot of people don't require repair. Now, there's certain ones that are just on the periphery that are moving, because when we do an MRI, you're lying down, so you're not moving. Yeah. So what could look like an undisplaced tear in an MRI can actually be moving more dynamically when you move. So some of those, if they don't settle, do require repair. Yeah. So repair is essentially putting a few stitches into the capsule and cinching it down to the meniscus. And what you want to do is stimulate the area to bleed. So you use a probe, you agitate the capsule, and you get some bleeding, and then you suture the meniscus back. Some people would advocate it's probably the suture that holds the meniscus in place. It may not actually heal. Yeah. There are certain circumstances where you can't repair when the meniscus is too badly injured, or when you have a situation where you have a displaced fragment or flap. There's lots of different configurations of tears. So if you have a tear where you have a little flap of meniscus that's kind of flipped under itself, patients often complain it's sort of like walking with a stone in their knee. Mm-hmm. Those patients typically don't get better. You see them yourself, where you just work in the range, but they still have that biting pain. They twist or get up from the chair or get into a car or walk down the stairs. And sometimes those patients end up going to partial meniscectomy, where you just remove the flap of the meniscus. And there's then the controversial area when you get into the degenerative meniscus. And the degenerative meniscus can come in a setting of early arthritis. And that's where there's lots of controversy about that. There's certain groups that advocate we never operate in degenerative menisci because it's not worth it, and surgery is a complete waste of time. And there's some truth in that, but I think we have to differentiate between surgery in the setting of arthritis, which I think there's very, very few indications for that. But in the degenerative meniscus, you can have the same configuration of tears. You can have flat tears, you can have displaced tears, and tears which are causing people lots of problems. And what you do is a meniscate, you do partial meniscating for some of those, and they tend to improve their symptoms. Now, you have to be honest with patients and say you're not going to probably change the natural history of developing arthritis in that group, but you're going to give them pain relief. So it may be that they can do more, they progress to arthritis quicker, but you're essentially just removing the offending article that's causing the pain. But you're not really going to address the arthritic element. That's the real key. So it's not, every patient is bespoke, and now we treat them individually based on the configuration of the tear. It's a long-winded answer.
No, that's good.
So consent, I think, was that the second
part? Let's go into consent. So in terms of physiotherapy and Optimus Health Group, we see a whole range of acute ruptured ACLs. We do injury prevention for ACLs. We also will work on plenty of people who have had meniscectomies or meniscus repairs plus ACL repairs. And so the question that we get asked quite often in physiotherapy as a profession is this whole ACL surgery versus conservative management approach. And so my question to you is in particular around the informed consent. What is the difference between informed consent of conservative management versus surgical? And your opinion.
So for me, I think informed consent is a really important part of any medical practice, whether it be someone undergoing surgery or someone undergoing a treatment regimen. And I think it's particularly apt in the setting of ACL injury. I think that certainly some people would advocate non-operative management for ACL reconstruction, and they would even go further than the groups I'm talking about. So not just the low demand group, they would go into the high demand and middle sport group. And I would argue that in that group, it's very important that the patient is aware of the risks of that treatment, just as we would explain the risks of surgery to a patient. I think that just to tell a patient, yes, you don't need surgery, it's very reassuring for some that surgery comes with a lot of trepidation and a lot of potential other issues or complications, but non-operative management has potential consequences too. And I think that as healthcare professionals, we have to be advocates for our patients, but we have to also give our patients all the information that is available. So I think for someone to have non-operative management, the person who is recommending it needs to be able to tell the patient that yes, there is a risk of re-injury, and you may not be rupturing an ACL which is already ruptured because it may not heal, but you have a risk of injuring other structures, which is really important. So some of the issues we see is young patients who go back to sport and they really do a lot of bad damage to their knee in terms of stuff which you can't fix, like a lot of chondral damage and meniscal damage. So I think that informed consent should apply to both treatment methods, and that patients need to be able to make an uncoerced decision about either method. So that's why it's often important to talk to a number of people and to give patients the information that they want to go with and make their own decision.
No, that's good. That's a really good explanation. And we've seen that plenty ourselves, even with clients coming and seeking second opinions with us as physios. And they've been through a conservative management or a non-operative rehab phase of say 6 months. However, they're still lacking in basic strength, and all of a sudden they've been cleared to return to train, and they come and see us for a second opinion because they've hurt their knee. And that's probably what you're talking about, is that the meniscus tears or chondral damage, the articular surface damage. And so one of the questions that we had was, what are some of the muscle groups that we should be strengthening to prevent that? And in terms of that, it's a very, very basic point, but what I wanted to say was a lot of physios and a lot of strength and conditioning coaches actually miss a significant portion of the knee stabilizers. We all know that quadriceps and hamstrings are very, very important for linear stabilization of the knee. But what we typically will see is that their adductors and their gastrocs, so their calves, have really been neglected. We're starting to see a lot of people come through where their strengthening of adductors has only started at 6 months when they've returned to train and they've come back with really tight and short groin muscles. And calf strength has just been atrocious. So from a physio perspective, maybe 6 months post, that's one of the things that I'd say is S&C coaches and physios really need to start looking at groin muscles and calf muscles. What about?
Well, I think it's something that we're also interested in looking at. I think that doing some biomotion analysis and looking more as kind of truncal control as well. And looking at gluteal strength. I think that's it seems to be the buzzword now in a lot of physiotherapy and rehabilitation, and everyone seems to be doing deadlifts to build up the glutes. Maybe it's a more cosmetic appearance thing, but I think glutes are really important. I think that we're probably learning a bit more about that. And you're absolutely right. I think, the old-fashioned doctor's prescription for physio was quads and hamstring strengthening. It's a lot more than that. And I think, we want quads activated straight away because we want to get extension straight away after surgery. That's the most important thing, I think, for us is to get range of motion. But you see a lot of people come back after ACL injury and they've built their quads up, but they're almost quad dominant, and they get a lot of patellofemoral issues afterwards as well. So I think it's really important that you look at holistically at the lower limb kinematics and how someone is moving, and be able to address if they have weakness in their calves have been neglected. But it's also just functional movements as well, that how, not just how far you can hop, but how are you hopping? And you're recruiting other muscles, or are you compensating? And these things are all really important to look at. And it's really good that you can do it objectively with some of the testing you're doing.
Well, that's super important in terms of, we will see a lot of people come and say, I've got grade 4 out of 5 strength in my hamstrings. And that's a very, very broad umbrella term. And we've been really passionate and vocal that needs to improve. So even just going to a point of doing a strength endurance test of your hamstrings to see how many single leg hamstring bridges you can complete before you either cramp or you fatigue. And, most people getting 15 to 30 is a good number. But again, that's also quite a large, broad umbrella term because it's a very isolated movement. So we're very passionate about using objective data, force plates, force pads, and seeing and comparing in a very systemized and structured manner of, how many newtons of force can your hamstrings produce at the end of range. And we've got some equipment here at Optimus that should be used. And I know that plenty of the English Premier League teams use them. The AFL teams all use them now as well. And Valve Performance have been fantastic in progressing that objective data collection.
I think that's really important. I think the other things we talk about using these objective measures for return to sport, and that's something that is a little bit tricky because Julian Feller, one of my colleagues, has written extensively on this, and it's very hard to use these objective data purely as yes, you can return to sport, no, you can't. And I think that certain people have interpreted the literature on these, and it's not always as accurate as you think. There's been a lot of controversy on this. And in one of the articles that Regrowth et al. Has looked at, and they've looked at all comers in terms of ACL and looked at the rates of re-injury. And that's not the rates of ACL injuries, rates of knee injury. And they have looked at the likes of limb symmetry index. And I've seen a quote recently about how if you're 1% under the limb symmetry index, you're 3% more likely to injure your knee. And I think that this stuff is very interesting. And I think it's one of the things which has promoted us to do further research on it, because we have the data available because we do a lot of prospective studies. So we just recently looked at our under 20s group of patients, and so these are the high-risk patients, male and female, and we looked at the strength and looked at limb symmetry index, and a surprisingly high number of them actually do reach above 90% limb symmetry index, which considers the
key ratio to get or percentage to get. But we found that there was no correlation between re-injury and whether someone was above 90 or less than 90. Now it's hot off the press, so we're just about to publish or we're about to submit it for publication. But so it's these type of studies that I think are really important to shed some light on where we're going. I think we're going in the right direction, looking at strength, but there's so many other factors that go into re-injury.
Yeah.
But the very fact that we're looking at it, I think we're probably going to understand it more. But I don't think we can be so dogmatic as to say this test will give you that risk factor and this test will do that.
Yeah.
I think we have to take everything into consideration.
It's one of the things that we're trying to educate a lot of our clients who are looking at returning to sport, in that it's effectively like a risk matrix, right?
Yeah, of course.
Where there's no, yes, you've passed all the tests and you won't re-rupture your ACL, or yes, you've passed all these tests. It's actually, there's probably 100 tick boxes that you've got to do. And if you complete 70 of them and return to play, it's better than completing 50 of them.
Yeah, yeah.
But you might still re-rupture if you've completed 70 of them. And it's that kind of education that we're trying to get out there, that, you know, there's no absolute. And I feel like research shortcuts and in particular infographics are very dangerous in this area.
Yeah, I think the infographic can be helpful in some regards to get across a key message, but I think when it's a bit more complex, to make some of the message more simple is not always as helpful. But I think ultimately we're all going the same direction. We want to reduce injury rates, and I think that's the key. And I think the better you put the athlete back on the field, probably the less chance they are to injure themselves. But it's a risky sport. They injured a perfectly good ACL to start with. So with doing a movement, they've done thousands of times. So I think that if we, prevention, as I said, is the key. And if we can work as well as we can to get them as good as we can, you hope that you reduce the rate of their injury ultimately. But it's a difficult topic. It's a very controversial area.
Yeah. Let's talk about osteoarthritis.
Yeah.
One of the questions that we had come through was, how bad does my knee have to be before I need a new knee, a knee replacement?
Yeah, so that's a layer of questions. It's complex. I think that once again, there's not a simple answer. I think from our perspective, like when we were going through training, there's a phrase, you have to earn your knee replacement. And I think that most patients will go through exhaustive non-operative management before you would consider a knee replacement.
Yeah.
And I think that one thing we recognize as people with arthritis is the importance of staying active and the importance of exercise. A lot of times patients come in with pretty advanced arthritis on x-ray, but you look at their function and you say, well, you're doing very well and you should continue as you're going. And the few factors that we feel are effective from a non-operative perspective are, weight loss. It's just pure physics. The more weight you have, the more load goes through your knee. If you lose weight, the less load, the less symptomatic typically. Improving your strength. So if you can get a bit of, control of all the muscle groups you mentioned, your quads, hamstrings, glutes particularly, and get it, perhaps improve your range of motion. Don't push it if it's not going there. It's probably a mechanical reason. Taking anti-inflammatories. If you have a swollen knee, your quadriceps don't work. They don't activate. So you need to reduce the swelling, and then avoid things that hurt you. So common sense is not that common. So just stop doing things that hurt you. If you're going upstairs 20 times and your knees hurts every time you come down, stop doing it.
Yeah.
And I think these are all the things that we're very aware of. The likes of the GLAD program has been really effective. And we as surgeons really support stuff like that, because it makes patients a hell of a lot better and in the short term. And then those patients who ultimately do come to total knee replacement do much better.
Yeah. So
it's a long-winded way of you're worried to have an Irishman on these shows because they tend to like to talk about. But one of the things, the real indication for knee replacement is refractory pain. So pain refractory to all of your non-operative measures, and particularly pain at night. And I think that you look at the natural history of people with arthritis, they have waxing, waning kind of effect, they have intermittent pain, and then it becomes constant. They can't function. You see it a little bit during the lockdown, that some people are just in extremes. So elective surgery was cancelled, but the certain patients just really cannot cope with the pain. They can't get a good night's sleep. And it's those patients, I think, are the ones with significant arthritis that we would recommend a knee replacement. And unfortunately, a lot of patients who have had previous traumatic events, the likes of ACL reconstruction in the past, who have injured their menisci, injured their cartilage, do ultimately come to knee reconstruction, or sorry, knee replacement at a younger age, and they're the challenging group.
And that's many different traumas to the knee, isn't it? It's not just the ACL surgery
it's probably the ACL surgery continuing to play sports. And so it's a complex issue, but we try to push it out as long as we possibly can, because there's really good studies to look at the expectations of patients. People who are highly functioning with arthritis, who have knee replacements, don't do very well. Whereas those people who aren't functioning well and who are severe arthritis tend to do a lot better when they have surgery. So we want to pick the winners, and we don't want to pick patients who aren't going to do well.
And in terms of physio, strengthening is so important, and getting muscle bulk back around those knee stabilizers. It works in two different ways. One is that the muscles will reduce the force of the knee, and number two is that the knee will be much more stable. A lot of people just think that the knee is a hinge joint, but it's not. There's a lot of rotational forces and a lot of accessory forces that go back and forth, even though they're much smaller compared to, say, a shoulder. And it's about strengthening that knee and stabilizing it. That's what that GLAD program does. We do run that at Optimus. We've got GLAD certified physiotherapists. I think it's a Scandinavian program.
I think it's in Denmark. The D is Denmark, I think, isn't it?
And so that's just a structured strengthening program that if anyone is thinking about, hey, I might need to see a knee surgeon, that's where we'll collaborate and really work side by side and strengthen and try and reduce any signs or symptoms.
Yeah, absolutely. And the vast majority of patients who come with arthritis, that's our conversation, is trying all those 4 measures. And we write them down on the page as and keep with the natural history. So it is very common.
Excellent. What's your favorite surgery?
ACL reconstruction. I love
Easy.
it. It's amazing. Just getting back from the lockdown, unfortunately, there's not many sports happening, so the ACL injury rate has gone down for the first time in 15 years. But because sports not being played, but it's a great surgery. I think that you just get excited about it. It's a very simplistic type surgery, and there's really 20 steps. And if you do all 20 steps correctly, it goes really well. If you don't do the step correctly, it can be a bit more challenging. But it's always nice to give people, let them back to what they love doing, and ACL reconstruction is excellent for that. Probably the surgery that the patients are happiest with ultimately is hip replacement. I think if you asked most orthopedic surgeons what's the best surgery we have in orthopedic, it's definitely hip replacement. It's probably the best surgical innovation of the last century, in my opinion.
Because it goes from absolutely debilitating, unable to walk,
to people coming in, throwing the crutches on the ground and giving you a hug after 2 weeks because they've finally rid themselves of the constant aching pain. So it's that's those probably ACL and close second hip replacement.
What else we got there? A couple more.
Foot surgery. How about arthritis? What's it called? Misconception of meniscus surgery. Kind of covered that. How about meniscus open chain exercises? That's probably your
so one of them was open chain knee extensions in the first 12 weeks loaded. Look, there's been a few studies around loading open chain knee extensions that used mathematical modeling around the strain on the graft within the first 12 weeks. And that mathematical modeling showed that the intra-graft strain was 0% when you're doing an open chain knee extension within 60 to 90 degrees. And so what a lot of physiotherapists nowadays are doing is saying that it's okay to load that in open chain. But what they haven't measured is the fact that the bone tunnels that have been drilled are actually under force with no hamstring contraction. And so the difference between a step up and an open chain loaded knee extension, we're talking, 20, 30, 40 kilos of loaded open chain extension, without the hamstring posterior vector pulling on the tibia, the what we see traditionally here at Optimus is that if people are doing that loaded knee extension in an open chain manner, we get maybe some tibial screw movement. Now, there's been no studies on it, and so it's a really interesting question that's come through. And so what we say is that, well, look, if we feel like that's a risk factor for graft loosening, given that the current research and the current studies only work on intragraft strain, we just say, well, if there's an alternative measure that we know is safe, it's kind of like the informed consent. We'll pick the single leg step up every single time. So at Optimus, we avoid any loaded open chain knee extension because we know that there's plenty of other exercises that we know for a fact are safer to get the quads working. So from our perspective, it's, if you've got guaranteed safe exercise and then a maybe exercise here, we'll always go for that guaranteed safe one. So
I think the only thing I could add, I think from a surgery perspective, one of the things for the first 6 weeks, all we're concerned about is range of motion. It's more about
getting that extension,
activation, and extension. There's been a really good study from a guy called Bertrand Sonnery-Catet, who's based in Lyon in the Santé group, and they've looked at over 3,000 patients who have had ACL surgery and looked at the rate of what we call cyclops syndrome or cyclops lesions, where you get scar forming in front of the graft, so it stops your full extension. And it's not a bit of the graft that can happen. A bit of the graft gets left behind or gets impinged, but mostly it's the fact that people don't get their early extension. So it's that people who are a little bit apprehensive, and that's one of the reasons why we want people to move their knees beforehand. So from our perspective, it's all about getting the range to start with, and then we kind of defer to your better judgment. But like one of the things in terms of the graft choice, it's a really important you could spend a whole webinar or a few webinars on that. But from my perspective, considering some of the things you're talking about, for a lot of the pivoting athletes we talk about, I would be a real fan of using bone, tendon, bone graft as well, because you're getting good bony healing early within the first 6 weeks as well. So that's one of the reasons why I like it. It's got a screw both ends, so it's quite very stern, rigid graft. Now, Melbourne would not be the greatest or the proponent of that. That we're more of a hamstring kind of end, more focused towards on quads now. But I think the one thing you do want to protect patients in the early period, you don't want drag graft stretching potentially or loosening. But a lot of the methods of fixation are a little bit different. People are using suspensory fixation, which is little buttons on the cortex of the bone, so they're not actually fixed in the tunnels with the screw as many, but they do. It's still probably the most popular way. But you just want to protect patients in the early period, let that graft mature a bit, and then work on some more of the kind of dynamic strengthening exercises. Excellent.
If we've got any runners watching, what are the most common things that you would see from a surgical perspective for runners?
So runners are probably the most healthy group of people out there. I think there's running doesn't really, in my opinion, doesn't have increased the rate of arthritis. I think if you look at across the various different populations, in fact, runners tend to have lower BMIs. They probably have lower rates of arthritis. There's a recent article by Paul Williams who looked at that. It was very, very good. So it was nice to see because I'm a runner myself. When you do see some of the running injuries, a bit of iliotibial band syndrome, a bit of that. More kind of chronic overuse kind of injuries, tendinopathies, particularly in female runners in their perimenopausal age, in the 40s or 50s, probably beyond 60s. They get a little bit of tendinopathy, particularly the proximal hamstrings. That could be an issue. So I think, once again, gluteal strength is really important in that group. And thankfully, you see some meniscal injuries. Normally they're out of a little fall or some twist, and that's unfortunate. But they tend to be a healthy group. That's good. In my opinion. And much against the common thought is that running causes arthritis and protect your knees, but
completely false.
I don't think it's true at all. I think perhaps if you're a competitive runner or sprinter, you may have slightly increased rates, but I think for the most part, running keeps you healthy, keeps your heart healthy. You'll probably die a lot sooner with sitting on the couch eating Doritos. That's my opinion.
So it's interesting to hear that BMI is such a large aspect of knee injuries. And so dietitians are important, aren't they?
Oh, massively. I think most people are more aware of the importance of diet. I think if you look at weight loss as a non-operative measure, they're probably the most effective for arthritis. Really, people don't lose weight purely by exercise. It's what you put in and what you expend. So it's if you reduce your intake of high calorific foods, I think you're going to reduce your weight. And I don't proclaim to be a dietitian, but it's just common sense. We would recommend people look at their diets, and they do it with the healthcare professional who's best suited to do it, which would be nutritionists or dietitians, to help them out on that. And I think that we can only just give the recommendation, but one of the things I do for all my patients is they get weighed when they come in, because it's something you have to talk about. And I think that to bury your head and not broach the important issue is neglecting your responsibility to a patient. I think that's really important.
We're very lucky. We've got Marley, who's an exercise physiologist, starting with us next week.
Great.
And so he'll be running some weight loss groups,
in
particular for lower impact and potentially people who have some knee injuries. So it's fantastic to see that exercise in correlation with dietetics actually might have a significant impact.
I think so too. It's like yourself, particularly doing kind of weight training, I think is really important, particularly as people age, but you get a great sense of euphoria afterwards. And I think that for me is part of the process of exercise and how it's good for weight loss, is that you feel better about yourself. You're less likely to comfort eat potentially, and I think that the whole feeling of exercise is a really good impact, particularly nowadays with mental health issues.
Very topical with
really
COVID.
Important. And my father's a psychiatrist, so I kind of speak a little bit on this because we talk about it a lot. And he would often prescribe exercise to people who have some anxiety issues or depressive issues, and just makes you feel better.
Fantastic. No, that's great to hear. Well, look, thank you very much for coming on and sharing your thoughts and letting us pick your brain a little bit.
No,
really good to have you on.
Long to pick it all. So.
Thanks very much.
My pleasure.